Are there any questions from the audience to the debaters, or me, or any opinions that we have not addressed during this debate?
I hope I didn't miss it, but some years ago, independent work done by Don Goodkin, who at that time was at UCSF, and from Giancarlo CONy, monitoring the brain on a routine basis with MTR, seemed to establish that some lesions, there was an MTR change that preceded breakdown of the blood-brain barrier as evidenced by gadolinium enhancement, suggesting that there was some primary event in the CNS that triggered the disease. I haven't heard too much on this observation, but I wonder if I could get some comments from you about this, whether you're aware of any further work that's been done on that, and what the nature of that primary event in the CNS might be.
Well, it is very challenging as an idea, no doubt about it, but still evidence is missing, I think. What it can be, there are probably many, I don't know what we could think, probably the integrity of myelin. But on the other hand, somebody may say, what is the reason that in leukodystrophies, for example, or in other myelin disorders of the CNS, what is the reason that we don't have the same behavior of the immune system as we do have in multiple sclerosis? Particularly now on the basis of the current findings from Kipnis group in the States, that there is a lymph system also for the brain, I think that somebody might very easily think that there might be something, probably a virus or whatever, although no viral components have yet been identified in the CNS. A trigger that might, in the CNS, that might probably trigger a systemic immune response. But unfortunately, I don't think that I am able to think of any factor. Generally speaking, I think that the interrelationship between the immune system and the nervous system from the embryonic life until we become adults might be very important. And this balance, if is not well controlled, then it may very well be that multiple sclerosis may be in response to this imbalanced relationship between the two systems. Yeah.
I think that's an interesting question. I think that with neuroimaging, I think it should be possible to visualize whether you can really have inflammation and neurodegeneration being independent of each other. So you could imagine a patient with a unilateral optic neuritis and then do just volumetric analysis of the visual pathway on that side, and there should be atrophy. And then look on the contralateral side, you know, where there's no inflammation, to see if you have a similar degree of neurodegeneration. I think that would be ultimate proof that the two could really exist independent of each other, at least in one individual. I don't know of any such studies. Most of the studies have looked at the corticospinal tract and always have shown that the contralateral side is never affected in individuals who really have ipsilateral disease. I think this was done mostly by the Oxford group. For me, in principle, it's actually difficult to conceptualize a patient without any adaptive aberration and how we would actually even diagnose such a patient, because we rely so heavily on the MRI scan right now, where we really visualize active lesions that are driven by adaptive immune responses. So I think some of these experiments could be done, but I don't think they really have been done to the extent that I would like to have this addressed.
If you allow me that, okay, this is, I think, I just make a comment. The problem that we have, the MRI tools that we have, and we talk about activity or inflammatory lesions simply because we see gadolinium enhancement, is again problematic, because gadolinium enhancement simply indicates the open of blood-brain barrier. It does not necessarily mean that we may have a perivascular infiltrates and ongoing demyelinating lesion, and this is something which may very well be identified if we perform during the next follow-ups additional MRI and see whether we have T1 lesions and for how long do they exist, or whether under this T1 gadolinium enhancement lesion there is a permanent T2 lesion, etc., etc., etc. I think that simply because we have these tools, and we try to do the best we can for our patients in our everyday clinical practice, these tools, the same tools do not allow us to make any safe, let's say, scenarios that might be candidate for research, for further investigation.
Just as an added point, sometimes new tools can reveal mechanisms that one wouldn't have thought of. So say, for example, NMDA receptor encephalitis, which is an immune reaction. In some cases, we don't even see MRI abnormalities. And one might say, well, there was no clear evidence for inflammation, but now that it's clear that there's an autoantibody, it gives us new insights. And with paraneoplastic disease, sometimes you'll see microglial activation, sometimes CD8 infiltration, different kinds of pathology, and discovering, it would be nice to know what the antigen is in MS. I think that would add a whole new dimension, but I think it at least gives some precedent of how things that one might not have thought were inflammatory until you discover a pathogenic factor, concepts can change.
No, I think that's a really great point. I think that the autoimmune encephalitis field is really going to change the way we think about CNS inflammation. Actually, it's going to lead to probably re-diagnosing many of our patients, because I think currently most of the things we diagnose, that's really based on the clinical presentation. So I think including patients with schizophrenia, I think a lot of those patients will eventually have an autoimmune encephalitis. And I think actually some of the patients that we see in an MS clinic, once we have the diagnostic tools, will have a different disease altogether. And so I think that's right, and I also think clearly those patients have inflammation that we cannot see but on MRI scan. So I think we're currently really lacking some of the diagnostic tools to diagnose them based on MRI.
So just a comment and perhaps a reaction. I think some of the difficulty, Nikolai, you had in trying to defend the neurodegenerative pathways, it's really hard to ignore the inflammatory side of it. But can we put them together in a way that, can you imagine that inflammation depends on the degree, can sometimes lead to a critical hit in the survival mechanics of a neuron axon component? And if you exceed it, you kickstart a separate process which no longer can be recovered from. And then depending on when you look, you might see the inflammation. Sometimes in the case of Prineus, you didn't. Maybe there was a hit, a maximal hit in that case, and all he observed was the apoptotic phase of the death phase of the axon component. So inflammation may be the culprit and in driving some separate process, which once you've exceeded a certain level, you can't stop it. And depending on it, when we look, we'll either see the dominance of the inflammation or we'll see the presence of the final coup de grace.
I would argue it's still dependent on inflammation, because you still need the initial event setting it in motion.
But because you don't see it doesn't mean it didn't happen. It could have happened before, and you weren't aware of that. And maybe that's what we see in primary progressive MS. I think if the recent trials are teaching us that those patients are not devoid of active inflammation.
May I? I want to comment on two issues which maybe previously also mentioned, but I think they are very important in relation to what Mark said and Brian. Well, I think that we must realize that multiple sclerosis is very heterogenic disease, and there are genetics who show that different types and so on. And our discussion, well, is related to that the MS is so heterogenic, so different processes, different steps, different immunological, not exact processes can go on. This is the first thing. And I think another discussion was that inflammation was a good guy or bad guy. And I think that, you know, we should also remember that inflammation needs also takes some maybe positive aspects of the regeneration as well, and neurotrophic factors and so on. So this is a very complex process, and I'm very happy that organizers took us chance to discuss this constant process, because it will continue for next years.
Well, if you allow me a last comment, because I'm not trying to change the voting with 50-50, just as close to what Professor Friedman mentioned previously, probably about the good part of inflammation, the neuroprotective inflammation, and the threshold above which there is no way out, there is going to be a neurodegenerative process. I just like to mention that CNS, and particularly brain, is not a passive organ. It knows how to respond, it knows how to control, because what I have the feeling, probably I'm wrong, from the discussion we did, we give the very first role to immunity. Of course, it is there, it is active, but don't forget, I think, that brain is not like our joints in rheumatoid arthritis, or even our Langerhans cells in our pancreas. It's an active organ which is able not only to resist, it also controls, and is able to control the immune system. Don't forget that we have TLR4, let's say, receptors on the neurons, on the neuronal cells, thus indicating that whenever these pro-inflammatory or anti-inflammatory cytokines are there to orchestrate the things, it is not only the inflammatory cells that react, it is also the neuronal cells that have a role.
Great. There are no more questions. I think this is
Thank you very much.
it for this debate.